Good evening, everyone. Welcome to the last edition of Professor A.D. Sir's Virtual Clinic 2.0. The journey began on 18th of May. Since spanning over the 2 months, we included stalwart speakers covering the topics which are not only important for the exam point of view as well as the day-to-day practice. So continuing with that, today we have an important topic, that is functions of hand and its affection. So to speak on that, I invite and welcome today's guest speaker, Dr. Terrance Jerome, to brief about him. Uh, Sir is extensively trained in hand and microsurgery. Sir did his fellowship from the Ganga Hospital, Coimbatore. He is the first Indian to qualify the European Diploma in Hand Surgery, and as well as trained in the USA as a part of ASSH International Traveling Fellow. He is the editor-in-chief of a Journal of Hand and Microsurgery since its inception. He did FRCS Class 2 in 2020. He has more than 85 peer-reviewed publications and delivered a number of presentations, being a guest lecturer, as well as a faculty in the various national and international platforms, such as Indo-Japan Handmeet and East Asian Handmeet in 2021. He edited the 2 books, as well as the wrote chapters on the hand and microsurgery. And he's been the mastermind behind the TNOA mobile app and the website administration. Sir, warm welcome from all of us. Very happy to have you in our webinar program, sir. Uh, so before handing over to the sir, we have one more announcement that as it is a last edition, we have a valedictory talk by the Professor Shantharam Shetty on the burning topic, that is how to face the theory and practical exams as well as career options for the young orthopods following this talk. So I kindly request Professor Dr. Terrance to share his screen and start the presentation. Over to you, sir.
Good evening and thank you, Professor Dr. A. Devdas, for this wonderful opportunity. I'm deeply thankful and indebted to this opportunity. And I'm very much impressed and thank you for this kind introduction. And the co-sponsors, the coordinators, Dr. Satish, and the moderators, and the postgraduates who have been in this program. Quick couple of words before starting the presentation. I think I should thank special to Professor Devdas. He is such a hardworking and really I feel really at this age I think it's a never stopping hard work which put him in such a position that like he's always interested in teaching orthopedics. Such a wonderful and a very hardworking surgeon I have never seen in my lifetime, and I wish him all the best. With this few wishes, this talk is basically towards the postgraduates. How are they going to face the cases which they come across in any clinical examinations? Do not worry about hand cases because you know the diagnosis before. Say, for example, this is what I was speaking with Professor Dr. A. Devdas. Everybody knows what's a wrist drop, and they know by seeing that it's a wrist drop. They know it's a claw hand. They know it's a what do you call a ape thumb deformity or a simian thumb deformity. What does the examiner want? They doesn't want you the diagnosis. They always want you how you make the diagnosis and how are you going to treat those patients. So with this short introduction, I have divided my talk into 3 portions. Most commonly seen cases. The first is the ulnar palsy because I was very much particular about the claw hand because that's what we want to understand or impart the biomechanics to the postgraduates. And then the ape thumb deformity, and finally the wrist drop are associated with the radial nerve injury. So these are the 3 most common topics you will definitely get in any given examinations. All examinations, we know that proper history, a clinical examination is the key to success because most of our cases are a short case. The examiners might be in a mood to get the diagnosis or a short history because they are short cases which needs only the specific pertinent points and how you come across the diagnosis. So they may not ask you about in detail about inspection, palpation, other examination, but then being a postgraduate, this is what the basic 10 steps you should follow in every case, being a short case or a long case. By inspection, what you could see, what you can do in palpation, and what are the basic tests or motor examinations which the examiner really wants to know, and the sensory examination. We all know that the claw hand or ulnar nerve injuries can be acute or delayed, or can be a Hansen's disease, which you come across are burnt out cases with all trophic changes in the hand, ulcers, or even fingers which are auto amputated. So these are the cases you come across in your clinical examination. It can be broadly divided into two lesions, a low level and a high level. The clinical picture itself shows that these two fingers are extended. Probably they had an injury at the ulnar aspect of the forearm, where a tendon might have cut or the ulnar nerve had been injured. So this classical picture says that this is a low level palsy. Why low level? Because the ulnar nerve is divided into based on the nerve which is given below the elbow. The first branch of ulnar nerve is the flexor carpal at the elbow. So the level below it's called as low level, and the level above is called as a high level. Here, this clinical picture, you can say it's a low level, it's not a low level. Why? Because the clawing may not be seen obviously in a high level because of the supply of the FDB by the ring and the little finger. That is being also injured in a high level, so that you may not have a claw hand deformity, or you may have a what you call a normal looking deformity with wasting. Similarly, you can also see cases like delayed cases with a clear-cut case of a claw hand involving the hyperextension at the MCP joint and flexion at the IP joints. IP joints in hands are proximal interphalangeal joints. This is proximal interphalangeal joints and the distal interphalangeal joint. So if you have any queries in or any thing which you need clarification, please feel to stop in between so that I can be more illustrative to the postgraduate, because this is entirely for understanding how are you going to get through with this case of ulnar claw hand or other cases. So this is a case of a low level palsy where you have a classical ulnar nerve injury with a claw hand. This is classical. Injury is somewhere here below the origin of the motor branch of the flexor carpal. So it's called low level. Why it is called high level? The injury must be somewhere above. It can be at the cubital tunnel, or it can be at the arm, or it can be even at the brachial plexus. So where the muscle supplied by the FTP of the little and the ring finger are also involved. So that's why you don't get the proper claw hand. Similarly, in an old injury to the condyle, humeral condyle, may also have a late presentation of tardial ulnar palsy. We all know that India still has a burnt out case of Hansen's disease. So this is a classical picture of a burnt case of Hansen's disease with all trophic changes, because these patients lack sensation, especially in the median and the ulnar nerve, because this commonly involves both the nerves, median and ulnar, commonly seen in ulnar nerve. And they have auto amputated finger, and they have flexion deformity, they have wasting of the palm, all classical finding of a claw hand, especially in burnt out case of Hansen's disease. And there are a few other conditions which may also present with compressions at various levels, which may not be so pertinent to the postgraduates. As I mentioned, the high or a high upper level brachial plexus injuries involving the C8T1 can also have this picture of a claw hand, or can have wastings of the on the hand on the both of the dorsum, and you can have both the hypothenar wasting and we call this classical claw hand. So all examinations should also start from the neck to the fingers. This is what I follow. Other people can also say that you can follow from distal to proximal, because if you follow from proximal to distal, you can easily rule out what are the lesions and what are the causes for various lesions. So if you start from range of from the shoulder, elbow, forearm, and the fingers, always have this. But classical examination by look, you can say that is there any increase in the varying angle or carrying angle at the elbow? Or in other terms, you can also do a shoulder abduction and ask them to internally rotate so that it gives pressure over the cubital tunnel, can also cause precipitate sensory numbness or hyposthesia or tingling in the little and the ring finger. It's also a provocative test for diagnosing ulnar nerve. So inspection always needs to be look at the attitude, the classical claw hand attitude. And we also seen that it has trophic ulcers, smooth, shiny, and dry skin because of one, hyposthesia, and because of the loss of dermal ridges because of the nerve lesions. And dry, scaly skins are also associated in addition to the wasting and flattening of the palm. Classically, you can see this intraosseous wasting. You can see the hollow between the extensor tendons here and also at the first dorsal intraosseous, and also the adductors are always wasted. Similarly, this is one provocation test where you can ask this patient to flex and you can ask the dorsiflex. By this provocative procedure, you're giving a sort of temporary compression at the cubital tunnel. If the paresthesia starts or it occurs for 60 seconds, probably this is called as an elbow flexion test. Patient might have a cubital tunnel syndrome. So the entire crux of our presentation today about the claw hand is how are you going to diagnose based on this 5 aspects. One, the special test around the thumb. What are the special tests you need to see around the thumb? And about all the intraosseous, both the palmar and the dorsal intraosseous. 3, about the thenar, hypothenar muscles. 4, about the MCP joint, which is more crucial. And 5, about the long joints. So to understand this, we'll start with the Froment side. So this is a video of a Froment side. If you could see this, you can say that this is a normal hand and this is the abnormal hand. Usually, if we need to press, we need to hold a book, you can keep the thumb extended position because of both EPL and FPL and the power of the adduction. These are things which keeps the book hold to your hand. It's called as Froment sign. When you do this, when there's a weakness of the adductor muscle, what happens, instead of using the adductor muscle, adductor function, instead of using the adductor function, this is the adductor function, they use the FPL because that FPL is intact, supplied with the median nerve. So look again this. This is classical sign of Froment's, which says that here the adductor is weak or absent, and to compensate that, he uses the flexor pollicis longus flexed at the IP joint to hold a book or to try book. So what does it interfere that? It infers that this patient needs an adductor surgery replacement. Similarly, if you ask the patient to make a, you call a pinch, to power pinch or a key pinch. Say for example, if you want to hold a rubber or something like this, if you could pinch this, and normally we will pinch like this is a function where the pinch will be like flexion at the IP joint and at the MCP joint. You have flexion both at the because of the power of the FPL and also the FPB, and you have stabilization of abduction and circumduction at the CMC joint. This is classical way of pinching. What happens here is because of the absence of the FPB, a part of the FBB, flexor pollicis brevis is also supplied by both median and the ulnar nerve. In cases where ulnar nerve is alone innervating the FPB, there will be paralysis of FPB. So because there is no flexion power at the MCP joint, it goes into hyperextension. Because it goes into hyperextension, there is a, we call it Z-shaped deformity. It looks like a Z-shaped deformity here. So this is a classical sign of FPB paralysis in ulnar nerve palsy. So what does it indicate? It indicates that this patient needs an adductor replacement. Always compare with the opposite side because there might be patients who have hyperlaxicity of the MCP joint, and always compare with the opposite side. So how do you examine the FPB? The examiner might want to say that you show me how you will examine the flexor pollicis brevis. Flexor pollicis brevis, I told you that it's the flexor of the MCP joint, not the IP joint. What we are testing is the FPL. This is the flexion at the IP joint that is supplied by the median nerve. And this FPB. See, the IP joint is in extension. This FPB is, partly supplied by the ulnar nerve and also by the median nerve. So this is a way of checking the flexor pollicis brevis. The IP joint should be in complete extension. Similarly, in this patient, we should also check for the abirector pollicis brevis. Why? There might be instances or there might be cases like Hansen's where you have both low median and low ulnar palsy. Here, you need to check, give a counter pressure at the base of the proximal phalanx and also check for the tone of the muscle. It's not that you ask them to abirect and leave it. You have to check for the tone. The tone is the one which gives you or grades you the good power of any muscle. Similarly, look at the way, how does this patient hold a coin. So what happens here, because of the flexor pollicis brevis weakness, he always tries to hold a coin with a collapse or hyperextension at the MCP joint. This is a classical of any ulnar nerve palsy which has weakness, especially the flexor pollicis brevis. In case of a combined median and ulnar nerve palsy, look at the difference. Here, the MCP joint does not go into hyperextension because both the flexor pollicis brevis is completely weak. The flexor pollicis brevis is supplied by the median and the ulnar nerve are completely weak. To compensate that, only the FPL is acting here, which is FPL is supplied by the median nerve in a high, it's a high level, supplied at the higher level. So it's only a low median nerve palsy, low ulnar nerve palsy, where you will not get the classical Z deformity. Instead, you get a classical flexion at the MCP and flexion at the IP joint. So should not confuse between an isolated low ulnar nerve palsy and a combined ulnar and a median nerve palsy. This is a classical example between these two patients, because you might get a case where there will be an isolated or there will be a combined ulnar and median palsy, ulnar and median. You should not get confused, or you should not only focus towards ulnar nerve palsy. Okay, I've seen a claw hand. It should be ulnar nerve. No, cannot be. There can be instances where a combined ulnar and median nerve palsy can be given at examination. This is one test you can differentiate. Other test is, if you ask them to, ask any patients to a pulp to pulp touch. So this is only possible if you have a good MCP flexion and if you have a extension because of the IP extension. If you have a good interosseous, this sign is possible, will be possible. In those patients where the interosseous and the lumbricals, the interosseous and the lumbricals are nothing but they flex the MCP joint. This is the MCP joint. They flex the MCP joint. At the same time, they keep the IP joints, the proximal interphalangeal and the DIP joints in extension. These are the functions of the lumbrical, very essential, very important functions. So because of this palsy, because of this injury, what happens? These patients cannot use their interosseous or lumbricals. Instead, they can only use the long flexors. What are the long flexors? It can be FDS, or it can be FDP. So these are the two long flexors which come origin from the common flexor origin and they insert to the particular point, especially at the level of DIP or the PIP joint. So they can only use this. So what happens? They only use this, and they instead of holding like this, they use the FPL for the thumb and the FDP of the index finger to make a pulp to pulp pinch. This is very classical of the ulnar nerve. So similarly, what does it indicate? It indicates that there is a complete interosseous or lumbrical weakness. In addition to that, if there is a collapse, there's a collapse in the thumb. So if the collapse in the thumb, it also indicates that there's a weakness or absence of adductor pollicis and the flexor pollicis brevis. Similarly, you watch this video. This is the normal side. This is the injured side. If you ask the patients to abduct and adduct, what you can see is it's a normal pyramid-shaped gap between the thumb and the index finger. Oppositely, if you ask them to abduct and adduct, they cannot do it. They cannot do adduction. What they will do is, watch here. Watch. This abduction is there. The adduction is because of the extensor pollicis longus. The extensor pollicis longus is the tendon which you can see here. It's always close to the dorsal interosseous and the adductors. Close to the dorsal interosseous and the adductors. Its function is partly supplies the adduction function. So why most of the surgeons, or why most of the claw hand, they do not need a adductor replacement, because this FPL can act as adductor, can act as a weak adductor. It is not going to replace the original function of the adduction, but it is going to resemble an action of adduction. That's why here is a trick point. So here, this patient, see, he uses the EPL, does not have the adductor, uses the EPL to adduct. And also you can see inverted pyramid shape because of the weakness here. Similarly, there's also another way to examine the interosseous muscle, the adductor muscle and the dorsal interosseous muscle. Why I'm stretching here is because for any pinch grip, you need these two tendons. The adductor should be tight, the first dorsal interosseous should be tight. So this is one way of examining. You can see this is completely wasting here, and the adduction is also taken care by the EPL. You can see the prominence of EPL. This tendon is taking care of this adductor, function of the adductor, and also the dorsal interosseous. So more important is that clinical examination says that this wasting in the dorsal interosseous and the adductor muscle. The other, now we have finished about the thumb. What are the signs you need to look at the thumb? The Froment sign, the pulp to pulp sign, the testing the interosseous and the adductors. Now we're coming into the interosseous muscles. We know that interosseous are the flexors of the MCP joint and extensors of the IP joint. So this is one classical sign called as Pitras testis sign. Most of the examiners, they would like to know this name. A few names. You need not remember all those names. These few names. See, look at this. The thumb is lifted and asked to abduct and adduct. This is one classical sign where this patient cannot do in this because of the weakness of the dorsal interosseous. You know that dorsal interosseous we have the mnemonic DAB. They are the abductors, and palmar interosseous are the adductors, PAD adductors. So the classical way of the thumb, which is in abducting, all those dorsal interosseous are abducting and palmar interosseous are adducting. So this is a classical sign for interosseous palsy. Similarly, a card test. The surgeon, the examiner may ask to demonstrate the card test. So the normal side, they can adduct and they can hold the card. Look at the involved side. There's a weak or a gap or inability to adduct the fingers because of the weakness of the interosseous. This is a test which is done in full extension of fingers. I'll come across some other thing also. So this is a test where it's done in finger flexion. Look at this movement closely. Here, to hold this, he uses the long flexor. He flexes the finger because of the long flexor in order to hold it. So it's a trick. So do not take away by the trick that he is holding the card. This is not the true adduction of fingers. He's using the flexion of the, see, he's using the flexor, using the long flexors, FDS and FDP here, and trying to hold this. So do not carry away that this patient has a intact adductors. He is using the flexors to hold it. So be careful. The other test is early lasso sign. This is a classical sign where we always ask to make a crossover of the middle finger over the index finger and index over the middle finger. So this is weak in this right side because of the paralysis of both palmar and the dorsal interosseous. We have finished two classical signs involving the thumb, the interosseous. Now we are coming to the hypothenar region. So hypothenar region contains all the abductors, digiti minimi of the little finger, and opponents digiti minimi of the little finger. We are going to look for the test of this related to the little finger. So this is called as Wharton sign. What is Wharton sign? You can see here. So when you ask them to do a namaste, go manakam on the lateral side, see, this is the area where the little finger is coming out. It's because of the unopposed action of the extensor digiti minimi. This is the fifth compartment, which is attached to the ulnar side of the little finger. So it is active. So it is pulling the tendon like this. Why? Because of the adductor is weak. It is supplied by the ulnar nerve. If it is intact, it will not come out. So when you do like this, a test, this comes out. So meaning to say that this has to be corrected. You can remove this EDM, reroute it, and bring it to the on the radial side to get this adduction. So this is a classical sign of hypothenar weakness. Similarly, you can ask this patient to make a cup shape. See, this is a classical way of checking the claw hand. Cup shape, a thenar, hypothenar, all the crease and a hollowness. This is a classical of a normal hand. But what is happening in this claw hand? There's a flattening of thenar and hypothenar, and there's no hollowness. This is a normal hand. This is the involved hand. And what does this simplify? This cup is the tone of the hypothenar muscles, opponent's digita minimi. See, there's a flattening here, and there's a complete flattening here, and you did not get the tone. So these are the tests. It's called as Masse sign, and the examiners might ask you about, demonstrate the Masse sign. Similarly, this is also a reversal of metacarpal arch. Make a fist. These metacarpal heads are not in same line. These are not same line. It indicates that the contraction of the opponent's digitae minimi and also the interosseous in between the metacarpals. So they contract and they keep a sliding angle of the normal metacarpal arch. But then what happens here, because of the weakness of the interosseous, they don't contract, they become one in single line, approximately 0 to 10 degree, and also indicates weakening of the hypothenar muscles. The other sign is that we call it confrontation test. Ask them to keep both little finger together and then see both are in equal tone. One has weakness, it buckles, it gives off. So this is a sign where this little finger is buckling off because of the weakness of the abductor digita minimi. So now I've finished about the hypothenas. We're coming to the classical MCP joint, which is a very crucial function or crucial role of the ulnar nerve, which is very vital. We all know that the definition of a claw hand is basically the Duchenne sign. Nothing but, see, look at the video, hyperextension at the MCP joint, and flexions at the IP joints. Similarly, as I mentioned that this is all the reason for the claw hand because of weakness of the interosseous and the dorsal, weakness of the lumbricals and the dorsal and the palmar interosseous. What happens is, why it goes into extension? Because we know that on the dorsal side, we have the extensor digit communis to all those fingers. Because of the interosseous and the lumbrical, which is not flexing and extending the IP joint, because of this, the EDC has taken over the role of the extension of the IP joint. They try to cover the loss by pulling the tendons. So EDC is hyperactive because of compensation of the weakness of the MCP joint flexion and the IP joint extension. And on the ulnar side, what happens? The long flexors and of the ring and the little finger, they are only working, so they cause flexion at the IP joint. And why hyperextension? Because of weakness of the interosseous, the EDC is taken care. The EDC pulls, which is intact, it pulls causing the hyperextension. So this is an examination. This is how do you, analyze or how do you understand the biomechanism of any claw hand. And what happens in a claw hand is, you should understand, when you extend the wrist, what happens? The fingers go into flexion. When you flex the wrist, the fingers go into extension. So this is called as a synergism or a tenodesis effect. This tenodesis effect is advantageous in claw hand because this claw hand is always a hyperextension at the MCP joint. When you flex, the deformity helps in extending the IP joint because of the basic tenodesis test. So this is called the Andrews-Thomas sign to demonstrate the tenodesis effect in a claw hand. Bouvier sign is very important because I'll take particular time in explaining this. So look at this video. You can see the first video. Hyperextension is occurring at the MCP joint. Hyperextension occurring and flexion is at the IP joint, as I mentioned the reason. But here, what happens? I'm stabilizing the MCP joint. That is, I'm temporarily doing the function of the lumbricals or interosseous by flexing the MCP joint. Automatically, the fingers go into extension. Because this is very crucial to determine what treatment are you going to give and how are you going to proceed. Whether you're going to do which sort of tendon transfer, and whether it is static, dynamic, or all these are decided by the Bouvier's test or Bouvier's angle, which I'm going to say. See, this is in another video. So he has a claw hand. By stabilizing the MCP joint or putting the MCP joint in flexion, all the deformity is completely correctable. Meaning to say that this deformity is supple, not fixed or not partially fixed. Now, the examiners might, few of the examiners might be interested in knowing few of the angles. It's a very simple way of telling you what exactly is wrong and how I'm going to correct it. So see, for example, this is a patient with this. So if you say a patient has a claw hand, good, that's well good. But what the examiner like me wants to know, what is the deformity angle? Come on, you tell me what is the angle? What is the angle, deformity angle? So it's nothing simple. Take a goniometer, measure the angle of flexion at the PAP joint, measure the hyperextension angle at the MCP joint. This is called as deformity angle. You add this, you'll get the deformity angle. So you can say, very well say to the examiner, sir, I have measured the angle at the MCP joint and the PAP joint. The deformity angle of such and such patient is such a degree. Okay, good. Then the examiner might know that, okay, you are focusing towards the treatment. You're focusing like, what are you going to say? What are you going to do for this patient? Very good. They'll ask you, what is an assisted angle or unassisted angle? Say, for example, the unassisted angle is, these are the angles, assisted and unassisted angles are specifically measured at the PAP joint. Why? Because we need to have extension at the IP joint. So this PAP joint is very crucial in doing the IP extension. So we are now focusing towards the IP joint and treatment is towards the PAP joint. For example, in all claw hands. Now, this is the unassisted angle. We have measured an angle of approximately around 80 degree here. This is the unassisted angle. We are not doing anything for this patient. This is the unassisted angle. Deformity is a combination of PIP and MCP, not this angle. Okay, so unassisted angle is only at the PIP joint. Similarly, assisted angle, what does do? Look at this video. So I'm trying to correct the deformity. I'm trying to correct the deformity. How? By flexing the MCP joint. I'm getting the original value of the angle. This is what the exact deformity. These are all because of high compensated deformity. What is the original deformity? When I flex it, watch the video again. When I flex it, this is from 80, it comes to 25. This is the angle which the patient exactly has. Okay, what is then? Now, you might also see that patients might come very delayed. Patient might come very late. So for example, around 10 months or 12 months, what happens? The position of long-standing deformity might cause a contraction at here, contraction at the PAP joint, because these joints are prone because it has not been functioning properly in the joint. So what we need to see is that look at this video. Now, he passively extends. While correcting the deformity, he also wants to know that, is there any contraction at the PAP joint? He can passively extend to 0, meaning to say that this is a completely supple joint. This is a completely supple PAP joint. What we need to do is just do a surgery to flex the MCP joint. That's enough. He can do everything. He can do flexion extension. The result will be amazing. So this is what the treatment plan. This is how a Bovius angle or Bovius test helps you in treating. So now, now you can understand. Now you can say, you can propose to the examiner, sir, I've done a Bovius test. I've done a deformity angle. I've done an unassisted angle, done an assisted angle, and I've also checked for any contraction or not. Sir, passively extending the PAP joint, this goes into 0 degree. It means to say that it only needs a procedure at the MCP joint. You can name the MCP joint procedure. It can be a static. It can be a simple Zancoli's lasso procedure where you're going to do a tendon transfer, take FDS, divide into 4 slip, pass through the A1 pulley, suture it back to the A1 pulley because you only need a MCP flexion. If you could do this, this patient will have a good function of the lumbricals and the interossei. The ultimate goal of claw hand injury or claw hand or claw deformity correction is not to get good function like this opposite hand, is to improve the function. That's what the examiner, that's what everybody wants. You cannot do 100% super fine surgery of just compared to the normal side. You're going to improve the function. So these are the tests which is going to help. Say for example, if you see that, if you could see that, see, Okay. Say, for example, if you are correcting this MCP joint, but then you have some extensor lag because of long-standing deformity. So what you need to do, if you have extensor lag like this, you are trying to passively extend. Okay. It is going, but then it's coming back. Meaning to say that the extensor tendons are weak because of the long-standing deformity. Now what you have to do, now you have to say to the examiner, sir, because of this extensor lag, which is passively correctable, I need to do all tendon transfer surgery to attach the tendon to the extensor expansion. Why? Because this gives the extension at the PAP joint. In addition, it passes to the volar side, to the volar axis of the MCP joint, and it comes dorsally, attaches to the extensor expansion to extend the IP joint. So there are plenty of tendon transfers, brands, and other Riordans. All these they use the extensor carpi radialis longus. They take from here, pass it to the ulnar side, bring it here, make 4 tails, pass through the volar to the MCP joint, take it dorsally here, and they attach to the dorsal expansion. Why? Because of they have a extensor lag. Understood? Now, the other thing is, because of the long-standing position, because the long-standing claw hand, there may be a shortening of the flexor. There may be an adaptive shortening. Because this constant position, there might be a constant adaptive position. So those patients can also, when you do a wrist tenodesis, it will not change. Because of the constant flexion contractions. Those patients might need a flexor lengthening and a stretching, and can also be treated with dynamic procedures. There are conditions like burnt-out case of Hansen's disease, where the deformity will be fixed. You cannot extend, you cannot do anything. So those are the patients where tendon transfer is contraindicated. You should know that in any patients, when the deformity is stiff, especially the PAP joint is stiff, you cannot passively move, cannot bend it, check it, do X-ray to see if there's any bone which is preventing or any injury happening. If there's no injury, the joint is good, you cannot extend because of severe contraction. You can try a serial casting, but those patients are not benefited. They will not be benefited by a tendon transfer surgery. Rather, they will be benefited by a PAP joint infusion. So this is a classical way of understanding. When you have a claw hand, this is what Prof. A. Devdas want to know. Identify the deformity, supple or does have extensor lag, or has a shortening, or it's stiff. Those have different treatment. So treatments are very, given in Campbell's orthopedics or any textbooks, but understanding the deformity is very essential. If you understand this, and if you say, I'm going to do a tendon transfer to extend the IP joint and flex the MCP joint, examiners will be very happy because you understood the problem. Without understanding the problem, you cannot say that I'll do a fusion, I'll do a Zancoli's lasso procedure, I'll do a ECRL transfer, 4-tail tendon transfer. So this will not work as far as the exam is concerned. In addition to that, we should also, for completion check, we should also understand that there are, to differentiate between the high ulnar nerve and the low ulnar nerve. You know that high ulnar nerve also has a weakness of the FDP of the little and the ring finger because it's supplied by the ulnar nerve. So here, this patient has an intact FDP, meaning to say that it's a low ulnar nerve palsy. It has intact. So in high ulnar nerve palsy, what happens if there is a weakness? So like you can say the examiner, sir, there is a weakness of the FDP to the ring and the little finger. So I'm going to tag those two tendons. I'm going to suture those two tendons to the middle finger so that they can get the FDP function. So the treatment is here. The treatment is based on your clinical examination. You need not say that this particular name transfer is going to use. You can only say that because of this surgery is going to be useful. This is what the examiner wants. Similarly, the completion sake, the examiners also want to know that whether you have performed a Tinel scan, because even though a short case, they will also know that how did you analyze, how did you come to a diagnosis, because this ulnar nerve is also a sensor in the motor nerve. So we all know that the Tinel sign should be from distal to proximal. There is also some situations where if you could compress at the Guy's canal, patient might have paresthesia or the little and also the little finger. You can see this. Patients are very classical. They only give you diagnosis. You are not going to come to diagnosis. They tell you diagnosis. Sir, here is the problem, and here is what they feel the problem. Similarly, So there is a difference between the low ulnar palsy and the high ulnar palsy. Always check on the oral side and the dorsal side. See, this patient says that this on the dorsum of the little finger and up to this level, this sensation is intact. He says the sensation is intact, meaning to say that the dorsal branch of the ulnar nerve is given approximately 6 to 8 centimeter, proximal to the distal radial joint, somewhere here. If this is injured or this area is numb or this area is hyposthesia, it means that the lesion is high somewhere in the cubital terrain. So this sensory symptom is also important. The dorsum is intact, it is a low ulnar palsy. The dorsum is not intact, it is involved, it means that high ulnar palsy. Similarly, one kit should be there for all examinations. It should include a filament, monofilament, a 2-point discrimination test, whips of cotton, a gonimeter, and sheets. So this is a classical example I told you, which is also very important. The dorsal supplied by the high ulnar nerve and the below the, the level of the wrist supplied by the, which differentiates the high and the low ulnar palsy. So since the talk is about functions of the hand and the affections, I should comment on few words about the impairment and disability. So simple, what is the difference between impairment and disability? Impairment is a loss of the anatomical portion. He doesn't have a hand, that's impairment. What is disability? Because of the loss, he has lost his function. He cannot write, he cannot pinch. Similarly, what is the impairment here? Impairment is a loss of the adductor, loss of the interosseous, the impairment. What is the disability? He cannot make a cup, he cannot hold, he cannot hold a book, he cannot write, he cannot hold object. So these are the disability of the ulnar palsy, like what you see. What approximately gets you in the ulnar palsy and the after effects of ulnar palsy is that you'll have normal forces like 70% are lost if you have a adductor pollicis, first dorsal interosseous, and FPB. These three are very important. If you have weakness, 70% of your function is lost. And these are all compensated by the FPL and the EPL I've mentioned in the previous video. So this is very interesting. We would all seen this picture in any textbook about ulnar palsy, but I don't think we have given understanding in how does this work. Look at this video. I've made it special for this. See, this is a normal hand. Look at this video. What happens is when he tries to catch a ball, okay, I'll stop here. When he tries to catch a ball, any hand function will start with flexion at the MCP joint. Watch this video again. So he is trying to see, he's trying to flex here first and then the PIP and the DIP. Understand? He's not trying to do this, he's trying to flex this, and then what happens here on the contrary, why does the ball immediately falls off? Because he doesn't have a cup, that is loss of the hypothenar, flattening of the arches because of weakness. And what happens the moment ball comes to him, he tries to flex the long flexors, not the MCP joint, because of the weakness of the interosseous. Watch the video here. See, he is only flexing the long flexors. I'll stop it here. See, what happens is, watch the video here. Yeah. So now, he's only flexing the long flexors. The FDS and the FDP is flexing. Because to give a pressure, you can give a pressure like this. That will give more pressure because it's functioning. Because to hold a round object, they give pressure to the long flexors. At the same time, to hold it, they keep loosen. The DIP joint function of the flexion is relaxed. Watch here. See, what happens is, see, here they have the MCP is flexed by the interosseous, and more power is taken care of, more power is delivered to hold the ball by flexion at the IP joints. Here the IP joints are not extended. Look at this picture. The IP joints are extended because the power is dissipated. The power is dissipated in the MCP joint to hold, to flex, to hold the ball, not to let it off. And they become lax here because the power is dissipated. Here, the power is equally balanced. MCP is flexed, is holding it tight by flexing the IP joint. So this is what the mechanism happens when you try to give a ball. You have seen this, all those pictures in any of textbooks. They'll show you a ball and then they'll show a movement. But you should understand how exactly the mechanism works in a claw hand. So you can watch this closely. This is a slow motion video taken for a better understanding. See, there is a wobble and fluctuation of the ball. A pseudo ball is created. Hyper extensions of the MCP joint and the long flexors are acting. So now what happens, instead to try to catch those ball, look at this. He's trying to flex only using the long flexors and the power is dissipated to hold so that he keeps the IP joint extended. This is the difference between a normal and abnormal. Similarly, watch this video. You can ask this patient to give a pinch grip because of the weakness of the adductors and the first dorsal interossei. What he is using is, he's using the flexor pollicis longus. Flexor pollicis longus, watch carefully. This is a flexor pollicis longus and he is using the long extensors to hold it like this side, a pinch to a side grip, which we never use in our day-to-day activities. We only use a pulp to pulp, this pinch, and a key pinch. Only we use this for key pinch to rotate or to start a car. So this is the loss of functioning. So sequelae of claw hand is that all those deformity, if it is the long-standing, they have all displacements, stretching of the dorsal aspect of the PIP joint, can have overlapping contractures. So final diagnosis, the examiner will be asking you, okay, now tell me what's the final diagnosis. So this is a classical sign. So if you say low ulnar nerve palsy, if there's a weakness of the interosseous, hypothenar lumbrical sensory loss over the little finger and the ring finger, and if there is involvement of the FDP of the ring and the little finger, it says that it's high ulnar palsy. In addition to this, if you see a weakness in the thumb flexion or a sensory loss in the medial aspect, it means to say that something in the medial cord is involved. You say that it's a brachial plexus sort of injury. So Dr. Satish, do you have some time? I can talk on the median nerve because sir also wants to talk about the median nerve.
Yes, please carry on.
I think I'll take 15 or 20 minutes, and if you're crossing, yes, please stop, please.
Once Professor Shantharam Shetty comes, we'll let you know. So
sure. Please break in between.
About, 9:05 or something. If we can finish, it should be.
Sure, please. The other interesting topic which Professor Devdas actually wanted to know is to tell the graduates, postgraduates, how to examine median nerve palsy like eighth thumb or Simian thumb. How does it affect the function of the hand? Similarly, like routine any causes for nerve injury, they also have a common common examination. Good evening, Professor Shantharam. Thanks for joining us.
No, I will love to hear you. Okay.
Sorry.
Go ahead, please.
Thanks. Just now, if you have finished about the ulnar nerve and the function.
I was hearing that.
Thanks. So quickly, I'll take 15 minutes and 1 or 2 minutes of your time, and then I'll try and finish it, sir. For the graduates, for the postgraduates, again, the common question is that the examiner might want to know that whether it is a high-level palsy or a low-level palsy. So how do you differentiate in a median nerve? Similar to the ulnar nerve, the lesion where you can find is that the low-level palsies are somewhere below the anterior interosseous nerve palsy injury at the level of the anterior, below the level of the anterior interosseous nerve. High level are somewhere at the elbow where the branches to the flexor pollicis longus is given. So to roughly to get to the diagnosis, whether it's a low level or ulnar level, simple examinations will tell you it's a low or high. If the FPL is acting, it means that it is a low level palsy. If the FPL is weak or doesn't have any involvement, it means that it's either high or somewhere at the pronator, somewhere at this pronator level. So we call it a high level palsy. As I mentioned in the previous talk also, a combined median and the ulnar nerve is also seen in Hansen's disease, where most commonly patients will have a common combined picture of claw hand or a wasting, obviously in the thenar region. So there was one more aspect which every postgraduate should know, may not come in exam, but there are a few cases where surgeons or examiners might want to know that why can't we say it's a compressive sort of neuropathy, because we don't focus on compressive sort of neuropathy. Most commonly is the carpal tunnel syndrome, and subsequently the others are the pronator and anterior interossei syndrome. Understanding this will also help you in giving a differential diagnosis. Say, for example, the examiner asks you, okay, it's a low level median nerve palsy. So what's your differential diagnosis? You should be right to say that it might be due to a carpal tunnel syndrome or an anterior interossei syndrome because of such and such factor. I am not putting this as a first diagnosis. I'm saying this because of post-injury or post-trauma. We all know that clinical examination is very vital. Look at the position of the thumb. This is a normal hand. This is a patient who had this, the median nerve injury, and it's a recurring median nerve injury. What you should look at this, roughly, if you put an angle along the long axis of the thumb and the index finger, this angle is approximately 40 degree. So keep it in mind 40 degree. If it is less or if it is close to the axis of along the plane of the index finger, this is what sir wants to know. Something like in the plane of the index finger, this is what, because of weakness of the epiductus and the opponents are combined together, and there is a weakness or a median nerve palsy. This is one clinical examination sign where you can say that this patient has a median nerve injury or a median nerve palsy. Wasting. In addition to that, always try and look for the trophic or trophic ulcers. This is a sign which indicates that this patient has a complete or hypoesthesia in the median nerve distribution, and he has suffered some injury because of this, and he doesn't have sensation of this wound. These trophic ulcers are classical about the sensory loss. This I was mentioning about the function. This is exactly how does a thumb should look. If you could abduct the thumb, this is how the thumb looks. If you could abduct the thumb, abduction is complete circumduction at the CMC joint, flexion and pronation at the MCP joint, and this is how does the abduction works. What happens in a median nerve palsy? Look at here. The thumb flexes to compensate for the abductor. Why? Because this is partly supplied by the ulnar nerve. FPB is partly supplied by the ulnar nerve. He doesn't use the abductor, but he uses the FPB to touch the opposite fingers or to do the function of the opposition. This is classical sign of how does abduction looks in a normal hand and a weak or a median nerve palsy. Or it can be close to similar to along the plane of the index finger. This is a classical picture of wasting. So obviously wasting on the left side compared to the right side. If you ask this patient to hold both hands together, because of the weakness of the FTP of the index finger and the FDS of the index finger, this is called as pointing index test. And this is a classical sign of a pointing index test. What do you call as a benediction time of blessing the sign. So what happens is here, see, this is a normal side. Watch this video, normal side. There's a flexion occurring at all the PAP joints and the IP joints. But here, see, the nerve, ulnar nerve supplies the little and the ring finger. So here, flexion occurs at the PIP and the DAP, and there's no flexion at the PAP joint of the index and also at the DAP joint of the index finger. And the thumb is adducted because of the normal or ulnar nerve supplied adductor cannot abduct, and it's lying in the plane with the index finger. Similarly, the examination should also include few of the surgeons or few examiners might also need, they may also ask you, should you grade that opposition? Can you grade the power of opposition, or what do you call the grading of this patient? So you can give a Kappanji score of grading. It starts from grade 0 at the base of the index finger, the crease, to all those creases and finally to the base of the palmar crease on the ulnar side. You can start from here, goes up to here, and finally at the transverse crease. It means that's a full grade 10. Similarly, examiners might also want to demonstrate the abduction test or a pen test. So this is what a patient of a median nerve palsy has. You ask them to abduct, they only can do either a movement at the flexor at the wrist, or they can only do a movement, flickering movement. It's 9 o'clock. Because of the ulnar nerve, which is innervating the FDP of the ring and the finger. Again, I'm stressing you, always give resistance to the testing while testing the abduction at the base of the proximal phalanx and feel for the tone. Asking the patient to do is not a complete way of grading the power of the abductor pollicis brevis. You should give a counter pressure and feel for the tone. Similarly, the muscle testing also involves the other muscles supplied by the median nerve. So, for example, for a pronation, ask this patient to sit comfortably on a table with both arms extended and look for the pronator. Stabilize the elbow and check for the pronator muscle somewhere here. Feel for the tone here. And for the flexor carpi radialis, you can ask the patient to flex the wrist and feel for the flexor. There are two tendons. We can counter, I can see there are two tendons. One is the flexor carpi radialis on the radial side, and next to is the palmaris longus. Few percentage of patients might not have the palmaris longus, but these two tendons is mandate for any clinical examination. Similarly, the palmaris longus, there are different way of testing the palmaris longus, touching the thumb and the little finger and giving counter, and keeping the fingers, the palm straight and giving a resistance to appreciate the palmaris longus. Similarly, the FDS, here what I need to emphasize is that by doing this tendon, by stabilizing the other fingers and asking the patients to move, in addition to that, I recommend you should always test for the tone. Once you flex this finger, don't say that he has an intact FDS. You should flex for the tone of the PAP joint, because the PAP should not be working. PAP can flex the FDP can flex the PAP joint, while stabilizing the other fingers. If you could flex, the FDS could flex the PAP joint. In addition to that, check for the tone of the FDP. It should be lax. It should be free. It should not be tight. It should not be tight. If it is tight, it means that the FDS is not flexing. The FDP is flexing. This is a test we should do. But then, in addition to that, you should always check for the tone of the FDP and also the laxness of the associated other fingers, because that confirms that only FDP is acting. Okay. Similarly, the FPL, it has to be properly stabilized at the proximal phalanx, and ask them to bend, feel for the tone of the FPL. Always should feel for the tone of the FPL. In addition to this, you should always check for the associated nerve, because median nerve injury can also be associated with ulnar nerve injury. You should not focus towards particularly for one particular nerve and examine for the other nerves also. The pronator quadratus is also a part of examination. You mask the effect of pronator teres by completely hyperflexing the elbow and then asking to pronate and rotate. Feel for the tendon while you make this test possible. The thumb apposition, as I was mentioning, should always feel for the tendon here, and should always ask this patient to hold. In addition to that, always check for the FPB, FPL, and check for the FPB. As I was mentioning in the previous examination, the FPB is the flexor of the MCP joint. It just flexes the MCP joint, not the IP joint. Should always check for the FPB, because this partly is also supplied by the ulnar and the median nerve. Similarly, a case of median nerve palsy, where, as I was mentioning, see this movement, this trick movement is because of the FPB, partly supplied by the ulnar nerve. There's two heads, ulnar and the median nerve, supplying that. Look for the movement. See here, the abduction is not working. The circumduction, forward flexion, pronation, and flexion to touch the finger is not working. Rather, the FPB, flexion at the MCP joint, is working in order to compensate for this. This is a classical case of a median nerve palsy. This is the normal side. You give a compression and feel for the muscle. Similarly, in a combined median ulnar nerve palsy, where this patient may not have adduction in addition to the abduction because of the involvement of the ulnar nerve. And this radial nerve compensation is which I mentioned in the ulnar nerve injury. Similarly, sensory nerve examination is vital because this gives about idea about the involvement of the palmar branch and also the individual digital cutaneous branches to the median nerve. So, in a nutshell, you can diagnose based on the involvement of the muscle you have examined, and then you can come to a diagnosis that this is what this patient has. If he has a prolonged teres palmaris longus FCR, we name it as high median nerve palsy. With involvement of FDS, the prolonged teres syndrome, anterior interosseous syndrome has the FDP, the index, middle, FPL, and palm, the prolonged quadratus. They are weak in anterior interosseous, and low median nerve has an intact FDP of the index finger. Similarly, the carpal tunnel syndrome, in addition to that, they all have APB weakness, lumbrical 1 and 2, and sensation in the lateral 3.5 fingers. Quickly, I'll brush through about the prolonged syndrome. Might cause compression of the median nerve proximally, and all the favorite examiners is like, what is this O sign? This is classical of the anterior interosseous syndrome because of the weakness of the FDP to the index finger. The patient cannot make a O. Instead, they use the FDS to instead they use the hyperextension of the interosseous to use the sign. This is classical of the paralysis of the palsy of the flexor digitum profundus and weakness of the FPL, which is supplied by the anterior interosseous. This is very classical of any examiner's part. Finally, about the carpal tunnel syndrome, most common is that they have nocturnal awakening because of the pain or paresthesia or dysthesia, and they have radial 3.5 fingers weakness. And the common test is the phalanx test or reverse phalanx test. And the other possibility is that you should always check for the tenderness, check for the Tinel sign, give a compression at the median nerve, and look for this patient abductor pollicis brevis, and also look for the Durkan's pressure test. Give compression over exactly over the median nerve, and look for 30 seconds whether this patient precipitates any symptoms or not, or this patient improves when you relieve the compression. So in a nutshell, the double crush syndromes are one entity examiner might ask you. It's very simple that you have 2-level compression. Most commonly, any injury which is compressed at 1 level is susceptible to have one more site compression. For example, they may have a cervical disc prolapse. In addition to that, they may have a median nerve compression. And similarly, they may also have cubital compression associated with the Guy's kernel compression. This is called a double crush syndrome. One final test is that very classical about this is a test where you ask the patient to sit comfortably, and then you ask them to abduct their shoulder and external rotate it. Okay, what happens in this, when you scratch over the median nerve, look at this, when you scratch over the median nerve, there is a cutaneous silence period, and immediately the arm collapses. Though not a sensitive test, some examiners might ask you to demonstrate a scratch collapse test for a median nerve injury. So, quick example about this patient who had low median nerve palsy, where you could do an EAP transfer to get this functional outcome, and similarly a high median nerve palsy, where we also published a series of articles. They got a good nerve functional outcome in median nerve injuries. So, in a nutshell, today I have touched about the 2 common topics which professor was asking to deliver to the students to understand what is the mechanism, how does it affect the function of hand, especially involving the ulnar and the median nerve palsy. We have a series of lectures involving the radial nerve, the brachial plexus injuries, and deformities and other aspects which will be covered in subsequent lectures. With this, I thank Professor Devdas, Satish, and the co-moderators, and Professor Shantharam, Shetty, for being here listening to my lecture, and thank you for your kind attention.
It was indeed a wonderful presentation. You beautifully demonstrated all the clinical signs in a video and pictorial format, which is able to the postgraduates will retain it for the longer duration. Thanks for your valuable time, sir. Even though you are in a busy schedule, you have given us a time and accepted the invitation. Thanks once again, sir.
Thank you, Terrance. Good. Wonderful.
Thanks, Terrance.
Yeah, without wasting much of the time, I invite and welcome today's second guest lecture, Dr. Shantharam Shetty, sir. So warm welcome from all of us, sir. Sir is going to give a valedictory lecture on the important topic, how to face the theory and the practical examination and the career guidance passing the exams for the in-court course. Sir is a well-known pillar in continuing the university, and he has trained many of the postgraduates. So I welcome sir to the webinar and kindly start the presentation.
Deepak, Professor Devdas will first give a welcome address.
I didn't want to be introduced.
Sure,
I told her that all the people
Thank
know.
you. Thank you, Shantharam, for coming and sharing your this one on the valedictory address for our postgraduates, mainly on their career guidance, etc., and also from the exam point of view. Being a great teacher to the whole world, you seek out a teacher as well and the examiner also. So I'm very much thankful to you for having accepted my invitation and giving their address today. Welcome, and please start your lecture.
Yeah. Good evening, Professor Devdas, Dr. Satish, and the chairpersons. And it was nice to hear Terrance for the last 20-25 minutes. It was nice to recoup your median nerve and ulnar nerve also. So this is the last day of this course. Professor Devdas and Dr. Satish have arranged, and it was nice to see more than 50 students from different parts of South India and even North India participating in this particular teaching program. And all my boys were closely going through this course, and it was really very stalwarts, right, from Dr. Rajshekaran to Dr. Professor Devdas to everyone who participated were very well known people, and culmination with the hand with Terrance. So in 20 minutes has been given to me by Professor Devdas, and I thank him for asking me to just deliver the valedictory address. But I thought I will share my thoughts on how to answer a theory examination question paper and what an examiner expects from you, and then on to clinical examination career guidance. So I made it very short, though it was a very long lecture which I delivered in one of the main conferences, because I will make it short so that everyone will understand how to. This course itself has made you understand most of the theoretical aspects and also the clinical examination part of it. But I will go on to how to really answer a theory paper. Now you have become you are prepared for the examination, and you have to face the theory examination, which is a must to pass, and then face the clinical examination to get your DNB or your MSR degree. It was Robert Parker, a British teacher in the pre-independent era, had the arrogance to say, I call it arrogance, because he said examination is the botheration of Indian nation whose occupation is cultivation. But today, examination for Indian nation is much better than any British national or American. It is a cultivation of determination to answer and deliver the best solutions from agriculture to medicine. We have gone to IT culture and shown to the world what our intelligent IT men have done all over the world and faced the examination so well. And so is the NHS and the American hospitals and even Australian hospitals are run by many well-known Indian surgeons or physicians. My presentation is mainly how to answer a question paper, having taken into consideration that you have prepared well for the theory exam by itself. Preparation for examination is a separate lecture by itself. Now we feel that you have prepared well for the theory examination, and how to face the theory examination is the subject of discussion. Almost all the universities or the DNB board have 4 theory papers. corrected separately, and 40% in every paper is a must, with an average of 50% with slight variability. It changes from university to university. They have an option strictly to make it 50%. But majority of the deemed universities and other universities have an option that if they average, if they get 50%, and even if the student scores 40% in one of the theory papers, he gets through. Well, here I have put two question papers, one from the university for MSR and the other for DNB examination, which is divided into four papers, as you know. Here I have put the first paper of each. And what is important when in the paper is important instructions has to be read. As an invigilator, as a chief invigilator, then as a dean of a college, and then as a vice chancellor, I have seen students, just as soon as the question paper is given, they don't even look at the instructions and just see the question number one. And if that is what they know well, they start writing without wasting. They think they are wasting time, but it is not so. Very, very important is to carefully read the instruction and come to this. Especially the DNB board has the instructions much more. As you see, there are nearly 12 points there compared to an MSR paper. All that is written in an MSR paper is answer in brief or answer in detail, what is to be done. But the time factor and everything has to be read in detail, and then only you proceed with the writing of the answer paper. Almost all the universities of the DN board have, as I told you, and they are corrected separately. 40% in every paper is a must. And most of the university theory paper is valued by all the 4 examiners, and the average is taken. Some universities have a rule that there is a variability of more than 10 marks, and between one examiner and the other in marking it, will go to the 5th examiner. In short, I feel, and all the senior examiners feel, it's a very fair game. And usually when a student fails, there is a blame game, as is by a student who hasn't prepared well or answered well. 99.9% we have done a statistical data of the retotaling asked for have failed. So do not unnecessarily ask for a retotaling of the exam unless you are 100% sure that you have done extremely well and there is no possibility that you can fail. Then only you ask for a retotaling, because there is no university which revalues the answers which are given. So because a fair game is given, if there is a difference of 10 marks, then the other examiner comes into play, the 5th examiner, and his mark is taken, or an average of that is taken into consideration. Whether it is a long theory question or a short question, divided short questions or MCQs, you will have to get trained and prepare how to answer. It depends on your university. Whereas in the national board, it is a very, very, very well modulated paper year after year, and very, very definitive instructions are given. And it is a practice in most of the colleges, universities to have a trial examination. And I'm sure Dr. Devdas institution has that, and our institution has that. Even my university has that both clinical and theory, and the theory examination, there is a trial examination, so that the students are trained from stress management to time management and how to write an answer paper. That will be a trial which where the students can be very confident. This is how you prepare, and the time has to be managed, and how to answer a question paper. Coming to stress management, it is important aspect of any examination. My plea to every student who appears for theory or practicals is don't be stressed. Remember, examination is the culmination of efforts you have put in for the last 3 years of your life. Don't burn the midnight lamp a day before, which many of us, even I have done that, and it is wrong. It is wrong to burn the midnight lamp a day before. Sleep well the day before and be fresh when you come for the examination. Have a good breakfast and talk to your best friends, your parents, and pray God and give you the strength to do your best. That is all you require. Don't be stressed because the last 2 hours or 3 hours of preparation, going through whatever, will not help. It is only the relaxation of mind which gets the best out of you. Once the question paper is distributed as told, follow the instructions very carefully. Read each question carefully. Spend 5 minutes and plan. If you do not plan, you plan to fail. So don't just dive into the theory answer paper. Strategize. Don't dive into shallow waters. You will always break your neck. Plan how to answer. Plan without action is, as I told you, is a fatality. Action without plan is a disaster, and only action with plan can lead to success. I would remember always the 4 R's. Read the question paper well, and answer paper you revise it, and refer yourself and relax. And you revise again the question paper and refer yourself, refer in your mind, and which come to your, if there is any journal you remember, you quote it, or all that. And if you want, you can use one of the sheets in your answer paper that is this thing. You can just mark whatever points so that you won't forget it. It's a good habit to write the salient points in an answer. There is no objection to it, that you can strike it off at a later date, at a later time. The other important factor in answering the answer and the question paper is the answer paper is time management, which is very vital. If there are 10 questions, divide your 180 minutes which you have to 16 minutes each for each question, and keep last 10 minutes for going through your answers, and preferably leave 5 lines after each question answer to fill in if it is necessary at a later date if you remember any vital points which has to be added. So time management, what we see many a times, what many of us have done is, you know a question very well and you take 20 minutes or 22 minutes for that and keep it on for that. So the last question will be the sufferer. And your handwriting is, you cannot help it now, but still for the juniors, if there are, you practice handwriting. All of us in the school, we had a handwriting class, and practice, it's a gain confidence, because see, practice is the only way. You go on writing answers. And Sachin Tendulkar in his last match, which he practiced, he says 10,000 times for his on drive. And Usain Bolt practiced for 5 long years and 4 hours a day. That is practice what is important. That's how he got 8 Olympic gold medals. Answer the first question. If it is in an MSR, you have an option that you can answer the first question just to appraise the examiner. Here is a brilliant fellow, and that is always half a mark or 1 mark mobilized. First impression, each examiner's eye it catches. But in DNB, you have to answer in order. The instruction is there. You have to answer 1, 2, 3, 4, 5, and then if there is a possibility, then you next 3 questions you moderate and write a better one next. And the last one, if you do not know at all, at least write something what you know, so that do not leave it blank. Here is a question. This I got it from the undergraduate. See what draw the lacrimal apparatus and mark the different parts was the question. The best paper was he has drawn the best of the pictures, colored it. What is the important marks here? Marked it. And finally, you will see that what are the apparatus and mark the different parts. He has done it. Whereas the average fellow, he went on writing instead of drawing first, he went on writing what are the different parts and what are their functions, wasted his time, it will not get any mark. What he gets the mark is just for the picture which he has drawn and naming the parts. Where the poorer fellow, he has jumbled up the whole thing and he hasn't written either the picture well, nor the parts. He hasn't completed all the 6 parts of the lacrimal apparatus. That's why it has to be, you read it and see that justice is done. Here is the question on orthopedic. Draw the anatomy of the anterior cruciate ligament and mechanism of injury and treatment schedule was the question. The candidate, instead of drawing the picture, wrote the anatomy of ACL and its attachment. Not only wasted his time, but also lost 3 marks. So read your questions carefully and answer to that. What was required is draw the picture, and then the mechanism, 3 marks, and then the treatment schedule. Question number 2, here, which are the common sites of giant cell tumor was the question, 2 marks. Latest classification, 2 marks. Histopathological picture, 2 marks. Management of distal radius, DCT is 4 marks. The answer the candidate writes is distal radius. It's a picture. The common sites is around the knee joint, not the distal radius is the second or the third common site. And the latest classification, Anakin, is the latest classification. It gets the mark for Anakin, but it is Anakin. It is a modified Anakin's classification. And the histopathological picture writes only of giant cells, and it doesn't write anything about the stromal cells and the pleomorphism. It doesn't get any mark. Management, he writes only curettage. And remember, curettage, 60% of the cases can recur. So he gets only 2 marks and he fails. So this you will have to see that, answer it to the point and what is asked for. Finally, in a theory paper, in the lighter vein, because as the dean and as the vice chancellor had a lot of problems dealing with students who are copying, and the invigilators are like hounds sometimes. Do not try to copy any, and do not take any devices. We caught a girl, unfortunately, in one of the university exams. She had a ear pin where the messages were sent. Remember, it is better to fail than to cheat. Don't get caught. Remember, there are CCTVs all around in an examination hall, and some invigilators may be sleeping, but some can be waiting hounds. Go through your answers in the last 10 minutes, correct even the spelling mistakes, and add on the last 5 lines you have kept vacant. If you have found new correct thoughts which strikes your mind, fill in the last 5 lines. It has been found that these 10 minutes can give you at least 5 marks more. Once you have done well in the theory examination, usually you have 2 to 6 weeks for your clinical examination. We go to the clinical examination. There is enough time to brush up. Luckily, there are a lot of courses all around the country for your clinical examination. You are all lucky students unlike us. We did not have what our professors professed was our gospel truth or the Bible. But today you have teachers like what Terrance did it, or the previous speakers did it every week of this course. They have taught you how to clinical examination. Points to ponder in clinical examinations are: primary aim is to pass. Many of the students, the brighter to the best of the boys, want a gold medal. They are stressed and they want. But your primary aim, remember, is to pass the examination. Many have failed because of the stress they are trenched. Remember this man who won 20 Grand Slams. He was cool as a cucumber. Whether he loses that point or not, there is no shouting, nothing. That is what is required. Clinical presentation in the YOC entirely depends on how well one has worked in the wards. That is important. Though it is late for the exam going, but that is what is important. It's a cumulative effect, a summation of 3 years. No textbook will describe individual problems for the patients. What you have seen in the ward is important. What you see in the ward strikes your mind. And always take it into mind whether the patient is diabetic, smoker, and take his vocation when you discuss the treatment. And hospital ward, remember, is a temple, and it has to be a temple of God. Sleep well, as I told you before the examination. Brush up the notes prepared 1-2 hours the day before. Listen to Carnatic music, which it is the best of the music as I feel, or whatever music you like, and talk to your friends, and then enter the examination hall. When you go to the examination hall, dress well for the examination. A clean shave and a clean hair, trimmed mustache or beard, a clean long apron with knee hammer, tape, watch, and marking pencil and torch. A polished shoe, even your nails clipped. That is the hallmark of a good orthopedic surgeon of tomorrow. Listen to the instruction of the chief examiner very carefully. The chief examiner will come and tell you, all of you are sitting there, he introduces the other examiner. And once the case is allotted you, plan your timing. Usually the long time, when there's a short and long cases, 45 minutes long case and 10 minutes together, but they will tell you. If it is all short cases, as in DNB now, they are given 10 to 15 minutes. You will have to stick out to time. Please do not say, sir, I want 5 minutes more, you will lose your marks and lose your medal. So stick on to the time and practice that, and that is what is vital. And the new pattern of examination in the DNB can be OSCE, usually 2 cases, and there's a ward rounds and table viva. You are very lucky DNB students now, because even if you have not done very well in the clinical examination, which used to be the case in our days or of late, even for in some of the MS examination, if you haven't done well in the clinical cases, you are gone. But in the DNB exam, if you have done well in the table viva or ward rounds and you score very well, you can still make it up in your clinical failure. So DNB is a fair examination. There are no clues. The atmosphere is new, because the southerner is posted to north, the northerner is posted to east, the easterner is posted to west. So unknown examiners like MS examination, where there is an internal to help you out. Don't try for clues from the expert. They may misguide you. Concentrate on your cases. You have done your job for 3 years, and basics, principles, and management. Learn Hindi. It's a national language, whatever it is, and English. And if you do not understand the particular language of the particular place, you can ask for an interpreter. And the Hindi, many people will understand, because you will have to take the proper history, expose the part, go step by step from the gate to the inspection. All these have been dealt in detail, so I won't go into the details of this, and conclude after all this from the inspectory to the special test. Even if you have forgotten in the examination, many times the students will say, "Sir, I have forgotten in the palpation. He has already come to measurement and he goes back to palpation." That it was unnecessary. The examiner would have forgotten, but you haven't forgotten. So you unnecessarily don't ask for it and go to, or if it is even primary diagnosis, conclude and summarize and put the salient features in your paper which is given to you, and come to a nutshell, and come to the management, treatment, ask the patient's occupation, the economic status of the patient, type of the job or study, and even the right hand or the left hand, and what the patient wants. You can always ask the patient what he wants as a treatment. These are the options. You can always tell the examiner, the patient wants this, and so I opted for this instead of a totally replacement something else. But think what is important for the patient as a whole. If you are definite, give a definitive first diagnosis. Like a Hypothenar disease with abduction and limitation, the child is between 6 to 10 years of age. And there is a limitation of abduction and internal rotation, classical painless gait. And that is, you can say, well, my first diagnosis, the most probable diagnosis is Hypothenar disease because of the limitation of abduction and internal rotation, or whether there is a possibility of a coxavara, which is not congenital coxavara, or adolescent, the age doesn't show. So you will have to abide by that. And if there is a case where a differential diagnosis, give the prominence 1, 2, 3, 4, and give the differential diagnosis in order. Give what is required for the patient. 50% of the patient will not require any operative procedures at all. It is always not necessary that an operation has to be done on a patient. Conservative management is golden always. And remember, if you leave it alone, the patient will be better off, and the examiner may appreciate it. But think about it, and you have worked in the ward and what to be done, and what your professor has professed to you. Do not give your opinion unless asked for in an examination, because the three people you should not argue with your wife, with your policeman, and with your examiner. And if you do not know the answer, wait for a minute. Examiner will give you a clue many times. Lead the examiner to what you know perfectly. Many times the students just tell something and they won't know about it. If you know some subject very, very thoroughly, so what is to be done for ankylosing spondylitis? What type of hip joint will you put? A what is it?
Mobility.
Yeah, but dual mobility hip to be done, or what type of hip which is required has to be taken. You take the YOC, you come to the instruments, the prosthetics, the operations, X-rays, pathology, and the specimens. These are in a DNB examination. And ward rounds, it depends on what you have done in the ward. And you will have to know what the basic things which are done in the ward. And whether it's MS or D, or some universities have it, some do not. So, but you will have to know about ward rounds when you are preparing for the examination. Be practical in ward rounds. prepare about external fixators, because that's the most common patient which is usually in the ward. Fixators are flaps which are there. The common operation is done. Learn about drains. DVT prophylaxis many times is asked. The antibiotic schedule is asked. Antitubercular therapy, many times antitubercular therapy, each institution differs. What is followed in your institution, you follow. And that answer the evidence-based and not what about it. So use all solution, kettle spots, sterilization, autoclave, everything can be in the ward, and you should know all about it. Well, I wish each one of you all the best in the examination, and I hope and wish each one of you will pass. Usually, Dr. Devdas students pass 100%. I wish all of you 100% result this time. And now, in another 5 minutes or 6 minutes, I will go on to carrier guidance. Thinking that all of you will pass, what after you pass? Guidance is a very difficult proposition. Guidance and advice is like castor oil. It is very easy to prescribe, but very difficult to take it in. But all the same, with our experience of me and Dr. Devdas, we will guide you what carrier guidance should be done. Me and Dr. Devdas, as per PHU research of the United States, belong to the pre-World War era. There's the pre-independent era. We are the traditionalists. And the next 47 to 61, Satish is little younger there, that the baby boomers, they do everything. They used to do everything, and they were the best of the scientists came in that particular era. But all of you belong to after 1990, and there you are the XYZ millennials. Most of you are XYZ millennials. So you are a different group of people. So you will have to be, mind your life will not be easy for you, like our life. And especially with the COVID-19 pandemics added, it will be very tough. Life will be tough and competitive. So plan now. If you do not plan, you plan to fail. Plan immediately after the examination what you want to do. Passing an examination is just a passport, you remember. You'll be thrown into the open ocean. You'll have to learn how to swim in this gruesome world. So what two of us used to swim those days, this is the number of people you'll have to swim through, and only one or two will get the prize at the end of the day. Remember, you are just raw iron. The strength of the steel depends on how well it is heated, cured, beaten, and shaped. I wish each one of you have trained well and have beaten and shaped to face the world of tomorrow. You decide what you want to be. You want to be a general orthopedic surgeon. You want to be a specialist. You want to be a teacher. You want to be a super specialist or work in a corporate hospital. It depends on your family commitment. Many times your financial commitment and the status and your vision and your dream. All this, it depends on that. Depends on where you want to settle down. You want to serve your own people in your hometown. You want to settle in a larger cities. Or you want to go abroad and see the fascination of the world around. Once you have decided, go and work for 2 years at least in a good institution, under a good mentor, have a good foundation. Whatever degrees or fellowship you have done, you will have to work practically. So to say that I can do anything what I want to do, that should be your strength of mind and profession. And have a good foundation, then only you can have a good mentor that you can follow and follow the principles of orthopedics. Try for a fellowship, go abroad and be global. And if you go abroad, I do not say that you learn much more than orthopedics than what you have learned here, but you learn discipline of work and work ethics, that you will have to come on time, you will have to go on time, and you will have to adhere to the principles and the ethics of the department and ethics and philosophy of orthopedic practice. Once you have chosen your career, the following character you have to cultivate to be a good orthopedic surgeon. Always be humble. Humility is thyself. Work hard. There is no alternative to working hard. You ask Dr. Devdas how many hours of work he has put in. He may not tell it, but I know that he was working 16 to 18 hours a day, almost throughout his life. And that is the theme. You see any orthopedic surgeon who is successful, he has been working very hard. It is not that that the success has come just like that. No, luck comes to those who work hard. Time management, which is very important. Go after, please don't go after money. Money should come to you. Maintain perfect record of the cases from day one of your practice. Keep up to date, attend conferences. That's the best way. You see, many times it disheartens you in a conference. Only elderly people like me and the Devdas will be sitting there at 8:30 in the morning hearing some lecture where there are 20 people, where a speaker has come all the way from United States or United Kingdom. But that you have to attend conferences, not to dance. Dance, you will have to dance. You drink, you will have to drink. But attend the meetings and hear what the experts have to say, and present and publish papers. Be research minded and be creative. There is always a pleasure to publish a paper, and be inquisitive and be innovative. Always take care of your health, which is quite important. Keep away from socializing too much. You are an orthopedic surgeon. People will invite you for dinner and for parties. Don't fall a prey to it all the time. Learn to say no. Don't procrastinate. Procrastinate is a great word, which I believe. Be an optimist and never be a pessimist. Procrastination is to postpone what is to be done today to tomorrow. That tomorrow will never come. Successful people do their work on that day itself. Be friendly, kind to your patient. That is the most important. Treat with compassion and with love. Patients, remember, require your compassion, not just competence from you. You will have to be competent is a part of the game, but unless compassion comes with competence, you are never complete. Love your family and find time to spend time with them, because that is a part of your life. Their support is a must for your going up in the ladder. The greatest evil of any profession is to be greedy, to hate and to be jealous of your own professional colleagues. Practice, if you are able, you will automatically practice will come to you. Practice love, practice harmony and forgiveness. If somebody has done something wrong, forgiveness is the best method. So, dear students, all the best again. Each one of you should blossom. It is our wish. People like Dr. Devdas and me and all of you have taught you, and Dr. Satish, who is here, and the two co-chairpersons who are sitting there, and the speaker who spoke just before me. Each one of them, and our wish is that all of you should become a good orthopedic surgeon of tomorrow. I wish each one of you a good luck in your examination. But remember, luck comes to those only who work hard for it. Thank you very much.
Thank you, sir.
Thank you, Shantharam,
Yeah.
for the wonderful way. As I wished, you did a good job for our valedictory address.
I didn't thank Devdas and Satish for this opportunity, and all of you. Nice to see you, and may God bless you all.
A pleasure, sir.
And Terrance and Satish and Devdas. Thank you.
Yes, sir. So it's really wonderful to have you here, sir. Thank you very much for accepting to be part of the valedictory address. And I think you spoke so sagaciously for our orthopods. I think this is an excellent platform for them to see you also. And we are loading this on YouTube, sir, so it will be seen by many people, many hundreds and thousands of times, I hope. And it's definitely going to help all the postgraduates and anybody looking for career guidance. It was excellent slides from you, sir. I think postgraduates, how to prepare for the exam, you spoke extremely well from all your knowledge and what you expect as an examiner. You have told them and also what the other examiners expect. That too, you have told them. It is an excellent talk for everybody, sir. We are so grateful to you for being here and giving the valedictory address, sir. Through this Professor Eddy's virtual clinics, we have done more than 20 lectures now, and in this short span of time, and it was all really stalwarts who have been here, starting from the inaugural session with Professor Dr. Rajshekharan, and the valedictory function with Professor Shantharam Shetty. We have had the tallest of tall leaders in the orthopedic education coming and teaching our postgraduates. I'm so glad many of the postgraduates will be benefited. It may be a little, for us, we started this for our postgraduates, but I'm sure almost the whole country, we are seeing YouTube hits of more than 500 or 600 already. So I think this is going to be staying there for a long time, etched in the digital world of these talks. I'm so happy that this Professor Eddy's Virtual Clinics 2.0 has come to end with such an excellent speech by Professor Shantharam Shetty. I thank our organizers, Dr. Deepak and Dr. Jaykumar, for taking this program every week, twice, so well, and coordinating with all the doctors and the teachers. I also thank Hallmark Events for making this a very professional event. They did try to bring in many students by a lot of emails and SMS, and I think that was also quite useful. And above all, I want to thank Professor Eddy for bringing this brainchild and making this work. And he personally spoke to all the teachers, all the speakers, and that made this the major success of this event. So I thank everyone for attending, all the postgraduates, and anybody else in the future also who would be visiting us on YouTube. Thank you so much.
Thank you, Satish. Thank you very much.
Thank you, Terrance.
Thank you, sir.
For the wonderful lectures. What all I wanted, you spoke about Ulnar and median nerve palsy.
Thank you, sir.
What the examiners want, also you have brought out everything. I'm sure all the postgraduates are very much benefited with your lecture.
Yes,
Thank you once again for participating in our virtual program. Thank you very much.
Good night, everyone.
Thank you.
Thank you, everyone. Good night.
Good night.
Good night. Good night. Thank you.